The most experienced medical personnel in the tent were the ones standing completely still, their hands empty, their eyes fixed on soldiers bleeding out less than 10 feet away. It made no sense at first, this strange reversal where the people who knew exactly what to do were doing absolutely nothing, while men with half their training scrambled to keep up with an impossible workload. Why would trained nurses with years of combat experience simply watch patients die when they had the skills to save them? The answer was typed on a single sheet of paper that had arrived 72 hours earlier, and by the time anyone understood the full cost of what that paper demanded, it would already be too late for the men whose names would never make it onto the official casualty reports, because their deaths would be classified not as combat losses, but as complications from insufficient medical resources. November 1950 marked the turning point of the Korean War, when Chinese Communist forces launched their massive winter offensive across the Yalu River, sending 300,000 troops streaming south toward United Nations positions that had pushed too far north in their pursuit of a quick victory. The 8076 Mobile Army Surgical Hospital sat 4 miles behind the 2nd Infantry Division's defensive line near Miryang, South Korea, a temporary city of canvas and desperation where 14 doctors, 12 nurses, and 89 enlisted personnel worked in conditions that would have been considered primitive, even by World War II standards. The unit had been operational for 152 days, processing over 9,000 admissions through an assembly line of triage, surgery, and evacuation that functioned with brutal efficiency when every element worked in harmony. But the harmony depended entirely on nurses who had trained for years to make split-second decisions about who lived and who died when helicopters arrived, carrying more wounded than the doctors could possibly treat. Captain Margaret Hartwell, the chief nurse, had served in field hospitals from Normandy to the Philippines during the previous war, and she ran her nursing staff with the understanding that in combat medicine there was no such thing as staying in your lane when soldiers were dying, which meant her nurses performed every procedure, short of major surgery, including starting blood transfusions, debriding wounds, administering emergency antibiotics, and making the terrible calculations of triage. That determined which casualties received immediate attention and which ones would have to wait and hope they survived long enough to get their turn. Sergeant Leroy Davis had transferred to the 8076 MASH 3 months earlier, after serving 18 months with the all-black 240th Infantry Regiment, a unit that Army leadership was quietly trying to dismantle as part of the slow and reluctant integration that followed President Truman's executive order, though integration in practice meant that black soldiers like Davis found themselves scattered as individual replacements into white units where they were expected to prove themselves twice as competent to receive half the recognition. He had volunteered for medical training after watching his platoon's medic save 3 men during an ambush near Daejeon, discovering he had both the steady hands and the detached focus required to work on human bodies when they were torn open and leaking, and the MASH unit represented something closer to equality than anything he had experienced in the infantry, because in the operating tent, nobody cared what color your hands were, as long as those hands could clamp an artery or suture an incision, fast enough to keep a soldier's blood inside his body instead of spreading across the dirt floor. Davis worked primarily with Dr. Howard Chen, a Chinese-American surgeon from San Francisco, who had spent the previous war treating wounded Marines in the Pacific and who taught Davis advanced techniques that most enlisted medical technicians never learned, recognizing that talent and dedication mattered more than rank or the arbitrary limitations that the Army placed on who was allowed to do what. And together they had developed an efficient rhythm in the operating tent where Davis could anticipate what Chen needed before the doctor asked for it. The trouble started on Wednesday, November 15th, when a massive Chinese artillery barrage hit positions held by the 7th Infantry Division 20 miles north of Miryang, sending casualties flooding south in numbers that overwhelmed every medical facility in the sector. Helicopters arrived in waves throughout the afternoon and evening, each one carrying 2 or 3 critically wounded soldiers who had been stabilized just enough to survive the flight, and the 8076 MASH processed them with the grim efficiency of a factory assembly line as nurses performed triage in the receiving tent, sending the most critical cases directly to surgery while stabilizing others who could wait. Captain Hartwell worked the triage station with Lieutenant Diana Foster, a young nurse from Ohio who had graduated from nursing school only 14 months earlier, but who had learned to make life or death decisions with a speed and confidence that came from treating over 2,000 casualties since arriving in Korea. And together they kept the flow moving smoothly, even as the number of incoming wounded threatened to overwhelm the system. Private First Class Robert Morrison arrived on the 6th helicopter of the evening, unconscious from blood loss, with shrapnel wounds across his chest and abdomen that had been temporarily packed with gauze by the forward aid station, but which had started bleeding again during the flight. Lieutenant Foster assessed him in less than 30 seconds, recognized he needed immediate surgery before he bled out, and personally wheeled his stretcher into Operating Tent 2, where Dr. Theodore Blackwell, a cardiac surgeon from Boston, was just finishing with his previous patient. Foster assisted Blackwell with the initial incision and helped control bleeding from a lacerated spleen while they waited for the anesthesiologist to arrive from Operating Tent 1, where he was managing another critical case, following standard MASH protocol where nurses functioned as surgical assistants when the situation demanded it, because there were never enough doctors to maintain rigid distinctions about who could touch what. Morrison died 40 minutes later from complications that the subsequent investigation would attribute to contaminated instruments and improper sterilization procedures, though the actual cause remained unclear because field surgery in a tent 4 miles from active combat involved unavoidable risks that peacetime hospital protocols never contemplated. But someone needed to be blamed, and the Army needed to demonstrate it was taking action to prevent future incidents. The order arrived Friday morning, transmitted through official channels from 8th Army Headquarters in Taegu. All female nursing personnel at the 8076 Mobile Army Surgical Hospital were hereby restricted from performing direct medical procedures on wounded soldiers pending completion of an investigation into medical protocols and sterilization procedures. Nurses would continue to serve in administrative and support capacities, including inventory management, patient documentation, and post-operative monitoring. All triage assessments, emergency medical interventions, surgical assistance, and direct patient care would be performed exclusively by physicians and male enlisted medical technicians until further notice. Violation of this directive would result in immediate court-martial proceedings. The restriction was temporary. Expected duration, 7 to 14 days. Captain Hartwell read the order 3 times before she believed what she was seeing. 12 nurses suddenly prohibited from doing the work they had trained years to perform. 14 doctors and 31 male medical technicians expected to handle the entire workload of a 200-bed hospital that was already operating beyond capacity. The mathematics were simple and devastating. They would not have enough hands to save everyone who arrived bleeding. Some soldiers would die waiting for treatment that nurses standing right next to them were forbidden to provide. She brought the order to Colonel Raymond Patterson, the MASH commanding officer, a career Army administrator who had spent most of his military service managing supply depots and who viewed combat medicine primarily as a logistics problem requiring proper procedures and clear chains of command. Patterson refused to countermand the order. He sympathized with Hartwell's concerns, but emphasized that neither of them had the authority to override directives from 8th Army Headquarters, and the investigation would proceed according to established protocols, regardless of battlefield conditions. The nurses would follow their new restrictions. The doctors and male technicians would adapt and manage. That was what soldiers did. They followed orders and overcame obstacles. The Chinese attacked again that night. 300 wounded arrived in the first 6 hours. Leroy Davis watched nurses stand motionless in the receiving tent, their hands empty, while men screamed for help they were forbidden to provide. The first man died at 0200 hours on Saturday morning, while Captain Margaret Hartwell stood 6 feet away with a bag of O-negative blood in her hands that she was forbidden to hang on his IV pole. Corporal James Chen, no relation to Dr. Howard Chen, had arrived with severe abdominal wounds and massive internal bleeding that required immediate surgical intervention, but all 3 operating tents were occupied with cases that had arrived earlier, leaving him waiting on a stretcher in the pre-op area, where the standard protocol called for a nurse to start blood transfusions and monitor vital signs until an operating table became available. Under the new restrictions, Hartwell could only document his deteriorating condition on a clipboard and watch his blood pressure drop while she waited for a male medical technician to become available. Except all the male technicians were already occupied with other patients, because the MASH had been designed around the assumption that nurses would handle these exact situations. Chen bled to death at 0217, his hand reaching toward Hartwell in his final moments, grasping at empty air because she had stepped back to maintain the required distance that regulations now demanded, and she documented time of death with handwriting so controlled it looked almost mechanical. Despite the fact that her other hand was trembling so violently, she had to grip the edge of the stretcher to keep it steady. Leroy Davis had been working continuously for 11 hours when he saw Hartwell standing over Chen's body, with that terrible stillness that came when a medical professional realized they had been forced to watch someone die from a preventable cause. He was in the supply tent restocking his field surgical kit when she walked past him without seeming to see him, moving with the mechanical precision of someone functioning entirely on training because their mind had temporarily disconnected from their body. And he recognized the expression because he had seen it on the faces of infantry soldiers after firefights where they had been forced to leave wounded men behind during retreats. Davis had 3 more critical patients waiting for him in Operating Tent 1, where Dr. Chen was performing his 6th surgery of the shift. But he followed Hartwell outside into the November cold, where she stood breathing the night air in great gasping lungfuls as if she had been drowning and had just broken the surface. She did not cry or scream or rage against the injustice of regulations that prioritized bureaucratic blame-shifting over human lives, because she was a career army nurse who had seen too many variations of military stupidity to waste energy on emotional displays. But she told Davis in a voice that carried absolute certainty that the order would kill dozens more soldiers before army leadership acknowledged their mistake and rescinded it. And by that time, the nurses would carry the weight of those preventable deaths for the rest of their lives, even though they had committed no error except obeying the commands of officers who had never held a dying man's hand. Davis returned to Operating Tent 1, where Dr. Chen was repairing a shattered femoral artery in a 19-year-old private from Nebraska, whose leg had been torn open by a Chinese grenade during hand-to-hand fighting in a trench system near the Chongchon River. The surgery required absolute precision because the artery was damaged in multiple locations, and Chen needed to excise the destroyed sections and graft in replacement vessels harvested from the patient's saphenous vein, a procedure that took 90 minutes under ideal conditions, but which Chen was attempting to complete in under an hour because 7 more critical cases were waiting, and every minute of delay increased the probability that someone would die before reaching an operating table. Davis functioned as Chen's primary assistant during the procedure, handling retraction and suction, and passing instruments with the practiced efficiency they had developed over 3 months of working together. But his mind kept returning to the image of Hartwell standing over Corporal Chen's body with that bag of blood in her hands, medicine that could have saved a life if arbitrary regulations had not transformed a trained professional into a helpless observer. The surgery succeeded, and the private would eventually walk again after months of rehabilitation in Japan and the United States. But even as Davis helped transfer the unconscious soldier to the recovery tent, he was calculating the terrible mathematics of how many other patients might have survived if nurses had been allowed to maintain blood pressure and manage airways while waiting for surgical intervention. The helicopters kept arriving throughout the night and early morning, bringing wounded from a Chinese offensive that had smashed through defensive positions held by the 2nd and 7th Infantry Divisions and sent thousands of United Nations troops retreating south in disorder. The 8076 MASH received 47 casualties between midnight and 0600 hours, numbers that would have been manageable under normal circumstances when nurses handled triage and initial stabilization, but which created catastrophic backlogs when only doctors and male technicians could perform those functions. Dr. Theodore Blackwell, the cardiac surgeon who had operated on Private Morrison before his death, worked 3 consecutive cases without pause before collapsing from exhaustion in the operating tent and requiring his own medical evaluation, leaving only 13 physicians to handle the surgical load. Davis moved between operating tents as needed, assisting whichever doctor required an extra set of trained hands, working on automatic responses that his body had memorized, even as his conscious mind struggled to process the chaos that surrounded him on all sides. Lieutenant Diana Foster spent Saturday morning in the administrative tent documenting patient records and updating evacuation manifests, paperwork that ordinarily took 30 minutes, but which now consumed hours because she had been prohibited from the work she had trained to perform. She had joined the Army Nurse Corps 14 months earlier, with idealistic notions about serving her country and saving lives, romantic fantasies that career had methodically stripped away and replaced with the practical understanding that military medicine was mostly about making impossible choices regarding who deserved the limited resources available. But even after witnessing countless examples of bureaucratic dysfunction, she had never imagined that Army leadership would deliberately prevent qualified medical personnel from treating wounded soldiers. Foster was 23 years old and had already assisted with over 300 surgical procedures, including amputations, chest decompressions, and emergency craniotomies, possessing skills and experience that many civilian nurses never acquired in entire careers, and now she was filling out forms while soldiers died within earshot of her typewriter. The breaking point came at 09:15 hours when a helicopter landed carrying 5 casualties from a platoon that had been overrun during a night ambush. All 5 were critical. All 5 needed immediate intervention. 2 operating tables were available. 3 men would have to wait. Davis performed triage in the receiving tent alongside Dr. Patrick Morrison, a general surgeon from Chicago who had been awake for 26 consecutive hours and whose hands shook from exhaustion and excessive coffee consumption. They made their selections based on who had the best probability of survival if treated immediately. 2 soldiers went to surgery. 3 remained on stretchers. One of them stopped breathing 40 seconds later. His airway had collapsed from facial trauma. Lieutenant Foster was standing right there. She knew exactly what to do. Insert an airway, bag him manually, keep oxygen flowing until a doctor arrived. 15 seconds of work. But regulations prohibited her from touching him. She looked at Davis. Davis looked at Morrison. Morrison was already running toward the operating tent with the 2 critical cases. The soldier's lips turned blue, then gray. Foster's hands moved toward her medical kit, then stopped, then moved again. Davis saw her face transform as years of training collided with direct orders. He made his choice. He grabbed the airway kit himself. Protocol be damned. Davis inserted the airway in 4 seconds, tilted the soldier's head back to open the passage, and began manual ventilation with the ambu bag, forcing oxygen into lungs that had stopped drawing breath on their own. Lieutenant Foster stood frozen beside him, her training screaming at her to help, while regulations screamed at her to step back, and the paralysis lasted only 2 heartbeats before she made her own decision and grabbed the suction catheter to clear blood and debris from the airway that Davis had just established. They worked in perfect synchronization. 2 medical professionals who had trained for exactly this scenario, performing a procedure so routine that it should have required no thought at all, except that every second they continued violated direct orders from 8th Army headquarters and placed their entire military careers in jeopardy. The soldier's color improved from gray to pale pink. His chest began rising and falling with assisted breaths. He would live long enough to reach surgery, which was all that battlefield medicine ever promised, and Davis handed the ambu bag to a corpsman with instructions to maintain ventilation every 5 seconds while Foster returned to the administrative tent before anyone in authority noticed her absence, though both of them understood that what they had just done could not remain secret in a medical unit where every action was documented and every patient required a complete record of treatment. Colonel Raymond Patterson learned about the violation within 30 minutes, when Dr. Patrick Morrison filed his post-triage report that included notations about airway management performed by unauthorized personnel on a critical patient. Patterson was a career administrator who believed that military organizations functioned properly only when every individual followed their assigned role regardless of circumstances, and he viewed the Korean War primarily as a test of whether the modern army could maintain proper discipline and procedure under battlefield conditions that constantly tempted soldiers to improvise and deviate from established protocols. He had approved the nursing restrictions without hesitation when they arrived from 8th Army headquarters, because investigations required cooperation and medical units were not exempt from accountability simply because they operated near combat zones. And if the restrictions created temporary inefficiencies, then the doctors and male technicians would adapt through increased effort and better time management. The fact that 2 enlisted personnel had deliberately violated those restrictions represented a direct challenge to his authority and to the principle that orders were orders regardless of individual opinions about their wisdom or necessity. Davis was summoned to Patterson's office tent at 1400 hours, still wearing surgical scrubs stained with blood from the 6 procedures he had assisted with since sunrise. Patterson sat behind a field desk covered with organizational charts and supply requisitions, the paperwork of war management that absorbed most of his attention, while other men handled the actual treatment of wounded soldiers. The colonel was 47 years old and had never heard shots fired in anger during his 23-year military career, having spent World War II managing logistics for training bases in the continental United States, and he carried himself with the rigid formality of someone who understood that maintaining proper military bearing was essential when you lacked the combat credentials that other officers possessed. He informed Davis that violating the nursing restrictions constituted insubordination under Article 92 of the Uniform Code of Military Justice, that the maximum punishment included dishonorable discharge and confinement, and that Davis would face a summary court-martial unless he provided a compelling justification for his actions that demonstrated the violation had been absolutely necessary to prevent immediate loss of life. The justification seemed obvious to Davis. A soldier had stopped breathing. He possessed the training to restore breathing. No doctor was immediately available. The choice was intervene or watch the man die. But Patterson wanted more than simple pragmatism. He wanted Davis to acknowledge that proper procedure required waiting for a physician, even if that meant accepting casualties, because military medicine operated on systems and hierarchies that could not function if every enlisted man made independent decisions about when regulations applied and when they could be ignored. Davis tried to explain that combat medicine was entirely about making independent decisions, because battlefield conditions changed faster than any command structure could respond, that the 8076 MASH had always functioned on the principle that the most qualified person handled each emergency, regardless of rank or gender, and that prohibiting nurses from treating patients had already killed at least 2 soldiers who would have survived under normal protocols. Patterson listened without expression, and then asked a single question that exposed the fundamental divide between administrative logic and medical reality. Had Davis specifically attempted to locate a physician before performing the airway procedure? Davis admitted he had not, because the nearest doctor was in surgery, and the patient would have died before anyone could retrieve him. Patterson documented that answer in his report. Failure to follow proper chain of command. Presumption of authority beyond assigned role. The court-martial would proceed. Lieutenant Diana Foster received her own summons 60 minutes later and faced nearly identical questioning, though Patterson's tone carried additional layers of disappointment because he expected better judgment from a commissioned officer who should understand that maintaining discipline required accepting difficult consequences. Foster had grown up in a small Ohio town, where her father served as the local doctor, making house calls at all hours and treating whoever needed help regardless of their ability to pay. And she had joined the Army Nurse Corps with romantic notions about serving her country that Korea had systematically destroyed and replaced with the practical understanding that saving lives often required violating the arbitrary rules that people far from danger imposed on those who actually did the work. She told Patterson exactly what had happened, admitted she had knowingly violated the restrictions, and stated clearly that she would make the same choice again if faced with identical circumstances because she had not spent 4 years in nursing school and 14 months in a combat zone to stand idle while soldiers died from treatable conditions. Patterson added her statement to his growing file of evidence: willful disubordination, refusal to acknowledge error. 2 courts-martial now instead of 1. Captain Margaret Hartwell learned about the pending courts-martial from Patterson himself, who called her to his office and explained that her subordinates' actions had created a crisis of authority that threatened the entire command structure of the 8076 MASH. Hartwell was 51 years old and had seen enough military stupidity to fill multiple careers, but she had never encountered a situation where the army was preparing to destroy the careers of two medical professionals for the crime of saving a soldier's life. She argued that Davis and Foster had acted properly according to medical ethics and standard MASH protocols, that the nursing restrictions were killing patients unnecessarily, and that Patterson should be fighting to get the restrictions lifted rather than prosecuting the people who refused to let men die. Patterson responded that his personal opinions about the restrictions were irrelevant because neither he nor Hartwell possessed the authority to override 8th Army headquarters, and the only way to maintain any credibility with higher command was to demonstrate that the 8076 MASH enforced all directives, regardless of whether individual personnel agreed with them. Hartwell asked what would happen when the next helicopter arrived with casualties that exceeded the capacity of the available doctors and male technicians. Patterson said they would do their best with available resources. Hartwell asked how many preventable deaths were acceptable. Patterson said that was not his decision to make. The next wave of wounded arrived 90 minutes later. 18 critical casualties from a Chinese ambush, 2 operating tables available. Davis and Foster both confined to quarters pending court-martial. The nurses forbidden to help. The mathematics of death were simple. Some men would not make it to surgery. They would bleed out waiting, and everyone would document it properly. The helicopters landed in rapid succession, rotors still spinning as corpsmen rushed to unload stretchers that carried what remained of an entire platoon that had been caught in an L-shaped ambush during a reconnaissance patrol north of the Chongchon River. 18 wounded soldiers arrived in various states of dismemberment and shock, their injuries ranging from sucking chest wounds to traumatic amputations to abdominal evisceration that required immediate surgical intervention to prevent death from blood loss or infection. And under normal circumstances, the 8076 MASH would have processed them efficiently through a triage system where nurses made rapid assessments and began emergency stabilization while doctors prepared operating rooms and planned the surgical sequence that would maximize survival rates. But circumstances were no longer normal because 12 experienced nurses stood in the receiving tent with their hands deliberately empty while Dr. Patrick Morrison and 3 exhausted medical technicians attempted to assess 18 critical patients simultaneously, a task that required at least 6 trained personnel working in coordinated pairs to have any hope of identifying which casualties needed immediate surgery versus which ones could survive long enough to wait for the second or third wave of operations. Morrison was operating on 27 consecutive hours without sleep, and his hands were shaking from exhaustion and adrenaline as he moved between stretchers, making split-second decisions that would determine who lived and who died. Except he was moving too slowly because one person could not physically examine 18 patients fast enough to prevent the most critical cases from deteriorating beyond the point where surgery could save them. Leroy Davis heard the helicopters from the confinement tent, where Colonel Patterson had ordered him to remain pending court-martial proceedings. A canvas structure normally used for supply storage, but which had been converted into temporary quarters that kept him physically separated from the medical operations he had trained to support. He could hear Morrison shouting for assistance and the sound of medical equipment being deployed, and the distinctive rhythm of organized chaos that accompanied mass casualty events. But the sounds were wrong because they lacked the usual efficiency that came from having enough personnel to handle the workload. Davis had been confined for 2 hours and had spent that time considering the implications of the choice he had made, understanding that his military career was likely finished, but finding it impossible to regret saving a man's life, even if regulations had prohibited that exact action. He had grown up in rural Georgia during the Depression, watching his father work as a sharecropper on land, owned by white families who treated black laborers as property rather than people. And he had joined the army partially to escape that system, and partially because military service offered one of the few paths toward dignity and respect that American society made available to black men in the 1940s, but Korea had taught him that dignity meant nothing if it required watching. People die when you possessed the skills to save them. Lieutenant Diana Foster sat in the nurses' quarters writing letters to the families of soldiers who had died under her care during the previous week, a task that usually brought some measure of closure but which now felt hollow because she was composing messages about men who had died fighting, while other men were dying in the receiving tent from bureaucratic cowardice. She could hear the activity outside and understood exactly what was happening because she had lived through dozens of mass casualty events during her 14 months in Korea, and her mind automatically calculated the timeline of how long Morrison could continue working before exhaustion caused him to make a fatal mistake in his assessments. Foster had joined the military with idealistic notions about honor and duty that now seemed like naive fantasies from a simpler time, but she had also learned that sometimes honor required disobeying orders from people who prioritized their careers over the lives of soldiers who trusted the system to protect them. Captain Margaret Hartwell made her decision in the receiving tent while watching a 20-year-old corporal from Kansas bleed to death because no one was available to start the blood transfusion that would have kept him alive long enough to reach surgery. She had spent 30 years following military regulations and climbing through the ranks of the Army Nurse Corps by demonstrating perfect adherence to protocol and procedure. But 3 decades of service had also taught her that some situations demanded choosing between following orders and following the fundamental oath that all medical professionals took to preserve life above all other considerations. Hartwell walked directly to Colonel Patterson's office tent, where he was reviewing supply requisitions, and informed him that she was rescinding the nursing restrictions immediately and that her nurses would resume full medical duties effective immediately because the alternative was accepting preventable deaths that no investigation or court-martial could justify. Patterson reminded her that she lacked the authority to override 8th Army headquarters and that implementing unauthorized policy changes would result in her own court-martial in addition to those already pending against Davis and Foster. Hartwell responded that she had not spent 3 wars learning combat medicine to stand idle, while soldiers died from bureaucratic incompetence, and if Patterson wanted to court-martial the entire nursing staff, then he was welcome to try explaining to 8th Army headquarters how the 8076 MASH had ceased functioning as a medical facility because he prioritized paperwork over patients. Patterson faced a choice that his career had never prepared him to make. He could enforce the restrictions and maintain his credibility with higher command while accepting that additional soldiers would die unnecessarily, or he could support Hartwell's insubordination and risk his own career by acknowledging that the nursing restrictions were creating catastrophic medical consequences. He was a career administrator who believed in systems and hierarchies and the principle that organizations functioned properly only when individuals followed their assigned roles. But even his rigid adherence to protocol could not completely overcome the reality that men were bleeding to death 50 yards from where he sat debating proper procedure. Patterson gave Hartwell exactly 30 seconds to leave his office and return to the receiving tent before he called military police to place her under arrest. She used 28 of those seconds walking toward the door. Patterson watched her go and did not pick up the telephone. The nurses returned to work. Captain Hartwell took command of the triage station and began rapid assessments of the remaining casualties, while Lieutenant Foster and 3 other nurses started blood transfusions and established airways and performed the dozens of small interventions that kept critically wounded soldiers alive long enough to receive definitive surgical care. Dr. Morrison sagged against a support pole and allowed himself 60 seconds of rest, while trained professionals took over the functions he had been attempting to manage alone. Davis remained in confinement because Patterson's authority extended only so far and he could justify looking the other way, while nurses violated restrictions but could not actively release someone awaiting court-martial without explicit orders from higher command. The mathematics of battlefield medicine shifted back toward sustainability, operating rooms filled with patients who had been properly stabilized. Survival rates improved. The system functioned again. 3 soldiers died anyway, not from lack of care, but from injuries too severe for any medical intervention to overcome. Traumatic brain injuries, catastrophic blood loss, damage that exceeded the limits of what field surgery could repair. Davis listened to the sounds of the medical operation continuing without him and understood that some outcomes remained beyond anyone's control, regardless of how many regulations they violated or careers they sacrificed. The war would continue. More helicopters would arrive, more wounded would need treatment, and somewhere in a headquarters far from the sound of dying men, Administrators would debate proper procedures, while people like Hartwell and Foster and Morrison did the actual work of saving lives. Patterson filed his report to 8th Army headquarters that evening. He documented the nursing restrictions, the violations, the casualties, his decision to allow Hartwell's insubordination. He requested immediate guidance on how to proceed with the pending courts-martial and whether the restrictions should remain in force given their demonstrated impact on survival rates. The response arrived 6 days later. The investigation was complete. The restrictions were lifted. The courts-martial were cancelled, no explanation provided, no acknowledgement of the soldiers who had died while trained nurses stood idle. Just a brief directive typed on official letterhead that restored the status quo as if nothing significant had happened. Leroy Davis returned to duty. He worked alongside Dr. Chen in operating Tent 1. He saved lives. He followed the protocols that made medical sense and quietly ignored the ones that did not. And he never forgot the lesson that Korea had taught him about the distance between what orders demanded and what morality required.